We are recording. Look at that. Amazing. So thank you very much, everybody. We'll go on to the next slide if that's possible. I'm not sure if it's Sarah or Brian who's turning the slides. All right, so just a reminder, the things we try and achieve through People First, respect for our staff, involvement, improvement for them, and making sure that we always look at patient care and value for the patient at the center of the work we do, and enabling teams to drive improvement. And mostly, I think we try and share their ideas and give them permission to crack on. So next slide, please. So 5 things we always try and achieve if you're ever interacting with the Quality Academy and People First. Hopefully what we help people with is clarity of purpose, give them the freedom to try some plan, do, study, acts, make sure there's really clear metrics which align to the projects and what their outcomes are. If possible, create improvement huddles, and I think you've got a really great example in today's presentation. And also, if possible, get them to use the team health routine, which we know has had a really positive effect around teams in the trust. Next slide, please. So we've got, it's Becky and Mike, a double act, apparently. There's an apology from Tamer. She's suddenly just been dragged off, so Marie's going to cover the ENT slides. Then we've got Diane, and then Oliver, and then Peter. So you're all very welcome. I will pause after each presentation, take a few questions. Becky, with no further ado, you're on.
Hello. Please bear with me because I'm really nervous, so I'll try not to stutter. But anyway, I'm Becky. I'm the ward manager for Bickley Ward, which is interventional cardiology. So I'm going to talk you through about improvements that we wanted to make to our ward routines so we could deliver swift but appropriate care to each patient. So it was important for us to ensure everyone was involved and listened to within the improvement discussions. So therefore, we had conversations with matron, senior and junior sisters, band fives, cardiology consultants, and doctors. And this was across both Bickley and Braunton being our sister ward. So we spoke about what improvements would be beneficial for all cardiology patients as well as the staff. Next slide, please. So traditionally, Bickley's 9 a.m. board round was led by the consultant, involving discussions mostly with the doctors and juniors about the patient's care and treatment plan. And even though the nursing team were present, they often didn't take part in these discussions and simply just recorded the actions pertinent to themselves. So to give greater confidence and leadership within the nursing team, and after gathering everyone's thoughts and opinions on how we could improve, as well as trying to incorporate information and learning from our incidents that we have had on the ward, we formulated a script which allowed the nurses to actively participate with more meaning to the discussions at the board round. So as you can see from the slide, this is the script that we created for the board rounds, and it sets out Bickley's expectations for each patient during every board round. This ensures that all pertinent topics are discussed with the relevant computer systems open and ready to expedite for understanding. This format also allows for a thorough but concise and swift discussion for each patient, ensuring all key areas of care are discussed and only moving on to the next patient when the nurse in charge initiates this. Next slide, please. So this isn't as neat as I wanted it to look, but anyway, this is our diagnosis to discharge board, and this shows the jobs that require completing, not just for that day, but preparing for the following day. So before the board round, the doctors document on here which patients each of them will be responsible for, so the nursing team know who to approach for patient-specific care and information. So at the start of the board round, we will call out and check who has which computer system open, as it is needed and required to be available for each discussion of the patient. TTAs are recorded for today and tomorrow, and then we have a follow-up mop-up huddle, which we do at 2 o'clock with the medical team to prepare and facilitate for discharges the following day. All diagnostics are recorded to ensure each patient has the procedure as quickly as possible, and then we expedite lists through our service line managers. The nursing team also checks and documents the patient's TEP forms overnight and adds any outstanding forms that require completion to this board, so the doctors are aware which patients have TEP forms and which are still needed to be completed. And then we also have added in our saline flushes with that, so the doctors are aware which patients need the saline flushes prescribing. We have found this board and line of communication extremely useful, and also following discussions with the team, the suggestion was made to have some of our junior doctors stagger in their start times between 8 and 9 a.m. and this was to help with TTA preparation and early discharge for the following day. Previously, the doctors did start at 8 a.m. and finished at 4, and with only one doctor covering 4 till 8. So with the staggering of the times, this allows us to have cover up till 5 p.m, allowing support with that TTA preparation. And then recording this information helps us facilitate less unnecessarily interruption for the entire medical team, meaning jobs are completed quicker. Next slide, please. So this is data for the first graph, which was kindly supplied by Paul Smith. This is the data that he feeds back to the medicine care group and is reflecting the whole of cardiology. So this data shows the long length of stay for patients, so patients in cardiology for more than 14 days. So the trend line shows a significant drop from the time the improvement project started at the beginning of March to the 8th of July when Mike Smith from the service improvement team stopped recording this. So as you can see, the starting number was 18 and the end number was on average 12. So that's a 33% reduction in the number of patients categorised as long length stay patients. The second graph is data collected daily from CARE and shows a snapshot of data between 8 and 9 a.m. The total ward length of stay is arrived by combining the length of stay for each patient together, which means daily the number will be in the hundreds. So for example, 26 patients on Bickley multiplied by each patient's individual length of stay in days. So the graph shows that the ward is always at maximum capacity regarding the patient numbers, but the trend line for Bickley's patient length of stay covering 7 months is downward. So the linear line showing the average number of days of the wards for length of stay starts at 340 and by month 6 has reduced on average down to 220. So that's a significant drop of 120 days, just over 35% over the whole 7 months in the ward. And the trend looks likely to continue, which is great. Next slide, please. So I feel all staff on Bickley should be immensely proud of the work that they do daily, but they should especially be proud of how they've embraced this process of creating and introducing new improvement ideas. And this also includes the amazing support and positivity that we've had from Mike Smith to help us achieve this. So thank you very much, Mike. Working within improvement quality, we often use the expression, those that do work improve the work, and this could never be more evident than on Bickley with the product given this significant improvement over where we have started from. These improvements have given great benefits to both patients and staff. So the patient gets to go home sooner rather than having a delayed stay. It's great for the patient's mental health as well as their heart health, but it's also great to the trust as we can now open doors to a larger number of people requiring medical intervention. Staff in cardiology should feel very proud for all these improvements that we can now clearly see on Bickley. Through early discussions with both the medical and nursing teams, not only did we acknowledge and suggest these ideas ourselves, but we've all really embraced the PDSA, so Plan, Do, Study, Act theory, which has boldly taken us to where we are now, 33% better than what we once were, and to continue with this percentage increasing. Thank you for listening, and I'm sorry about the shaky voice. Has anyone got any questions? Please be nice to me.
Becky, first of all, you did an amazing job there, really well controlled, really nice slides as well, and what an impact. I got one question. If anyone else got a question, could they please put it in the chat, because I won't be able to see all the hands go up. Do you feel it's being sustained?
Yeah, I do. We do have challenges, and the challenges have mainly been trying to get more the medical team and consultants involved with it. I do feel it's being sustained how we're rolling out the board round each day, and I feel with our red to greens that we're doing for each patient now, that will only better it and help with our improvements and kind of seeing if we have any delays, specifically identifying what delays that will be, and then we can obviously target that. It was just kind of giving the people the encouragement to have that, you know, initial confidence to lead it, which we have done throughout the team.
Yeah, really, really well done. And I know I've got Kelly Haynes Brown on the call, so I assume this work feeds into the work that's ongoing now with specialty standard work and our approach to red to green.
Absolutely, Richard. Yeah, the team have been amazing here, but yeah, all feeds into what we're trying to do as a care group. Yeah.
Really well done.
Thank you.
That's excellent. So thank you very much. You may obviously stay and listen to the rest because there's some quite nice presentations coming up. But you are really great, really well done, and really well done, Mike, in support as well. And I also understand this has taken like weeks and weeks and weeks to get you here because every time we put one on, it was a holiday or a clash day. So it's great that you've come and presented. So thank you.
Thank you.
I think next we've got well, it was going to be Tamar, but next we've got Marie as standing in for Tamar as ENT admin lead.
Yeah, thank you. So obviously ENT were part of the admin improvement exemplar as well, is now sort of nearing completion on the admin improvement programme. Next slide, please. So part of the programme is looking at the various sort of digital aspects within the sort of areas that they use, and also things like missing rows, their workflows and routines and roles and responsibilities. So working with areas to sort of move from red to green. Next slide. So part of the improvement within the team is to complete the checklist. So the plan is to sort of go from red to amber to green, and ENT have done a lot of work in the area sort of with their typing processes. So they now sort of do their letters in chronological order. They're using the new VR system and the systems they've put in place before they've been able to transfer to the new system, and they've included now a person that works from home each day, which they can increase with demand to cover the letters on the new Solventum system. And then they have a process where all letters are printed each morning, and electronic sign-in. They're now having a lot more letters immediately signed by the clinician, so reducing delay for patients, and they have a daily review and chase. Missing outcomes, so that all clinicians are using In Touch, and they do have checks in place to sort of outcome anything that hasn't been done within sort of 24 to 48 hours. They're looking to improve that further. And electronic in-tray, which I've got a bit of a slide on in a minute, but they're just now starting to move towards implementing that and getting rid of the paper pigeonhole system they had in place. They're doing work with routines with staff and starting to look at sort of new starter packs, competencies, and having sort of rotas in place for support sex so people understand what the expectations are. Office environment, so they've done some work to ensure their areas are clear and uncluttered and everything's labelled and can easily be found by anybody coming into the area. Filing, I've got a bit more of a slide on that in a minute, but they've introduced an excellent file and go system and are looking to be up to date in the new year. Data quality, they have introduced the new spreadsheet, which is used to sort of track weekly and monitor improvements, and they have the regular weekly one-to-one meetings with the staff. Next slide, please. So they've introduced weekly improvement huddles. So this started with the bookings team, and they've been looking to increase their utilisation of the clinic's booking, which I think they've increased up to 92%, down from I think 80%. And they've now introduced this with the secretaries to work on the backlog filing and to also listen to sort of their ideas and implement changes within the team. They have a really good production control in place. The staff know what their expectations are with things like typing letters, so how many they need to hit each day, and it can be flexed to meet demand, and look at staffing and sort of again long waiters, which they're looking to reduce how many need to be booked, and lots of other things. Office environment, so they've done a lot of work to make the areas tidy and desks clean at the end of the day, so if anybody was to have to use a desk, it can be used, and the team just feel a lot happier and less stressed because it feels a nice place to work. Next slide. So filing, they had 12-foot filing in August, so they've implemented CME mornings when the clinicians and nursing staff are undertaking CME to review their filing. They've reduced this in 2 sessions down by 50%, so they're now at 6 foot. This is looking at sort of what is filing and what is confidential waste, and they've now got a file and go system in place because of the turnaround of letters. They're going in the files and going back to Bush Park really quickly, and they're using all admin staff from bands 3 and 2 to complete this, so there's no sort of delays if the support secretary is not around. Next slide, please. Electronic in-tray, so again this is quite good with the clinicians being able to move the admin from paper folders to electronic in their inbox. So this is Mr. Canan, and he's just started, and he absolutely loves it. It's saving him a lot of time. He's able to do it at home, so he's got children, sometimes has childcare issues, and he's just been able to do it anywhere, and they've seen a quicker turnaround in the results, and the ones doing paper are now standing out with their turnaround, so their aim now is to get it rolled out from everywhere. Next slide, please. So the impacts and benefits, so patients are receiving their letters sooner, there's clear visual management within the team and team engagement with improvement ideas and understanding their expectations, and they no longer use overtime within the secretarial team. So from September they've reduced their discretionary spend in the team, and there's no NHSP. Next slide, please. So lastly, next steps is to get the Solventum letters over to Hybrid Mayo to release more admin time, to engage the rest of the clinicians with the electronic in-tray, for the secretary and reception starter packs to be completed, to continue with the CME filing to reduce the backlog, and by doing this they'll be fully green on the checklist. Any questions?
Well, firstly, Marie, you did a great job. Really well presented. Shame Tamar isn't here to also take some credit.
Yeah.
I know the interview team really well, and they'll be really proud of the work they're doing,
Yeah.
and have really got on with it. Do you think it's having an impact on some of the money side as well as all the quality sides and turnaround?
Yeah, definitely. I mean, they've reduced their overtime, so they're not reliant now on overtime. I think there's good governance in place with the processes. So things like electronic admin, they can get a copy of the email that they've sent over to evidence that it's been done.
Yeah, really well done. And I'm going to go back to Becky's point. When you involve people at the front, at the coalface who do the work, all these changes are really possible quite quickly. So well done, everybody. And Marie, thanks for standing in at short notice. So next, I think, I can't see any more questions. You've got lots of compliments. Next, I think up is our very enthusiastic NICU lead who came and sought us out to say, Richard, there's some stuff going on and I want to be part of it and I want to do it, and then very much led her own way through it. So Diane, over to you.
Thank you, Richard, and thank you to you all. Thanks for inviting me here. I do hope I can stay to the 5 minutes. So as Richard said, my name is Diane Keeling. I'm the neonatal nurse consultant down here, and I work with an amazing team delivering care to definitely our smallest patients, because our patients range from 400 grams upwards, but arguably also our most vulnerable, as you can see from some of these pictures. And what I really wanted to capture within the presentation is the why, the how, and the now as to why we chose to do the improvement huddle, but importantly as well for us, what next and what that looks like. So can I have the next slide, please? So the why is a really easy one. So that's about our patients and our families. And the picture that you can see here is actually relates to what Richard was talking about before, as our Penner Award. What's happening in this picture is this is a baby who went down to the Secret Garden here at UHP. It was one of the first times we took a ventilated patient down. And what you can see in that picture is the multidisciplinary team effort to actually get that to happen was huge. And what I really wanted to capture within the huddles was that actually this is very much an MDT approach. We rely so heavily on our team. The gentleman on the left is actually a technician who oversaw everything from a technical point of view to us getting down there. We've obviously got some transport nurses in there. We've got the consultant in there. We've got our equipment supply person in there. And importantly for me as well, you can see we've got a student nurse in there. So the whole thing of Grafton this was that everybody's responsible for QI and everybody has a role in QI and could contribute to that. So that's very much what we wanted to capture. And the whole thing that's happening in this picture as well is about this is patient driven. You know, this is a patient who was very much, can we go outside? You know, this is end of life care for a patient. Is there any chance of us having time outside before the patient sadly died a few days later? So this is really, really important for us is what can we do for our patients and actually really investigate what's stopping us doing that for our patients. So a bit of a switch on the question, if you like. So if you go to the next slide. How we did it, so getting your head around the board in the first place for me was a bit like, oh my God, what does this look like? But actually, it's not that hard. And one of the best things that Richard ever said to me was, just start. Just do it, because you procrastinate so much and you think about, I want to get it right. What does it look like? And that was the best bit of advice, because actually when you start, you can see from the board, it's a bit of a blank board because we really want the board to be about them. And I wanted the huddle to be about them. So it was very much how they wanted it to go. So actually starting with a blank board and just getting started is the best advice. Our top left bit is about our ethos, if you like. It was, what did we want? What was our overall aim? And for some of you, you might think this is a bit fluffy, and I'm going to really dispute it and say it's about psychological safety. We said the improvement huddle had to be a safe place where everybody's voice was heard, everybody could come to, and everybody could say, this is going great, this is not so great, and what it was, but actually have that confidence to do it. And for those who think it is the fluffy stuff, I would very much take you back to our trust ethos, which is the other thing we wanted to link with. So in relation to our civility, and definitely for those who aren't in maternity care, you might not be aware that a lot of our criticism and our reports that have come through from Ockenden and the Francis report are all around team culture, and actually the impact that that has on our productivity. So we very much wanted that to be our ethos, because we know how reliant we are on the whole team. So it did start off as a blank board. Each session we go back to that, this is our team purpose. And we were like, how does this look for you? And this is our very first huddle. I didn't want to be going through the idea of the huddle over and over. So the teams thing in the top right initially started off as, this is the introduction to the huddle. We are sharing it through Teams, and then that got disseminated to everybody who wasn't there. But what we have used with Teams is actually going forward, we open it up to those who would like to join us for our huddle from home, and that seems to work well. We sometimes get people who join in and sometimes we don't, but we have that open as an option. So that's pretty much what the board looked at in the first place. And that picture is honestly not just the first picture where everybody was there. That is very much what our huddle looks like. And I'm sure the quality assurance team can guarantee that it is, that we do get very good engagement from all members of the team. So if you go to the next slide. The now, what it's looked like. So it's quite interesting as to how it was driven forward. If you like, it started that we did talk about psychological safety, but we didn't have our goal, our culture where we wanted it to be, but we needed to assess where that was going. So we didn't initially have our team culture up there or our team ideals. So we waited for a few weeks until people felt safe enough and had an understanding of the board. And then we did say, okay, what are we doing well? What does this team look like? How safe is it? What's our values? What goes really well? You know, do we work well as a team or do we not? And with them, the team helped, the quality improvement team helped us generate our keywords. And going forward, what we do is every so many weeks, we do an assessment of where we're at. Is this going well? You know, as a team, are we being really civil to each other? Simple thumbs up, thumbs down, or not wanting to vote? And that in itself speaks absolute volumes. We did get quite a good team evaluation starting off with, and we've kept that going. And it's a little bit hit and miss. You know, if people are having a bad day, they'll often come and they'll be like, no, I'm not feeling so good today. But that's important in itself, that they feel they can vote. And I think what we are seeing is less neutral and more voting one way or the other. So for me, that is an absolute success because they are feeling in the safe place that they need to be to do that. The other things that you can see on the board are some of the PDSAs that we've decided to focus on as a team. So, and we give updates at the huddle and say, okay, this is where we're up to, what's happened. And just to give you a bit of an example on how important the MDT is on that, one of our very first quality improvements that came out was in relation to name bands, that not all our babies had 2 name bands on. And just before that horrifies anybody, as you say, we go back to the fact that these are 400-gram babies. So actually getting name bands that are appropriate and do not damage the baby's skin can be very challenging. So we had to go around what we were going to do, and we agreed that one of the bands could go on the baby's tube instead. But that had implications for which equipment we needed to increase. So the very fact that we had a technician in that team, she was like, that's not a problem. I will make sure that they are on order for you and that you've got an increased supply. So I know that they're going to be more going out. Brilliant example of what that looked like. And that was one of our very first PDSAs that went through. We do have a little envelope so that people don't feel able to speak up, that actually they can pop an idea in there, and we pull out those every huddle as well to say, how's it going? Oh, this person would like to talk about this. And what I would say is the one of the pictures you can't see, which is a little purple one, which is my one with the caveman pushing, which I pinched from Richard's booklet when you do the training, the caveman pushing the square wheel. That is very much what it feels like on a very busy day on our neonatal unit, that everybody's just so working in silos, so doing their own thing, and do not have the headspace to stop and think, what can I do different? And the 15 minutes that we give to a huddle, and I keep saying that, sometimes it's more valuable on the busy days than what it is on the quiet days. You might get better turnout, but it's actually more valuable because you get them out of that space into the room to stop and go, what is stopping me doing the best for my patient? What's going well? And sometimes it's something like a computer's not worked for the results all day in ITU, but it's not until they come to the huddle that they tell us that. And actually there's always a senior person at the huddle. And sometimes it's a really simple solution. It's like, no problem, I can get somebody to fix that for you now, or we can change it over and put another one there. And it sounds really simple, but if they've not got the headspace to do that because they're just so busy dealing with the workload at the time, it can be a big barrier. So I put a lot of emphasis on the fact that this is your 50 minutes, please use it to contribute, but also to take a deep breath and tell us, what can we do next? So it's not, that it's not all been plain sailing. There's some very, very good things, but definitely the unit acuity and short staffing does affect people's ability to think whether they can or can't attend. We definitely seen the same people wanting to come and the same people wanting to not come. So it's really, really important that we actually rotate. And so I make it very clear each time we're having a huddle, if you've not been to one recently, can you please make sure that that's the person who steps out the room and gets covered by a colleague? We generate a lot of quick information at these. They are very full on. There's very little silence in our huddles. Everybody has lots of ideas and lots to say. And it's how we share that information that's captured within the room with those who aren't there, because otherwise the pace of change can be moving too quick for those not who've been involved in the process. And it's okay to say, we'll share it through an email, but the reality is people don't look at their emails, which is why we're having the huddle to have the discussions. If everything was shared via getting everybody in the same room at once, which doesn't happen, or via emails, it just wouldn't happen. So the huddle addresses a lot of those issues, but we do have to make sure we include everybody who's not there. And we absolutely do have situations where people have come to want to share a grievance or wanted to come to get their point across, and that's been overpowering for others in the room. And I go back to this is a multidisciplinary team huddle. It's not for one person, it's not one professional's voice. This isn't just for our consultants, it's not just for our nurses, it's for everybody in that room. And I'm always very proud that actually when we do have our technicians or anything come into those conversations and we feel they can speak up, that's brilliant. Definitely had successes. Time out and headspace, people are getting that even on busy days. They are trying to get there and they really use it properly. I'm not allowed to say it, but I did actually have cakes for one of them because we had a celebration, because I was told I had to be in the zone for this, but we have had cakes before and that has worked too, to get them there. We do get quick fixes. Some of them are really quick fixes, and it's just like, if we, they haven't that time to share that with us, we can literally step out of the unit and actually get that sorted, and knowing that that makes a difference to the patient care on that day there and then is brilliant. And as I said, the MDT is a massive success, or everybody does still keep coming. And building momentum. The best compliment I've absolutely had, and it was only the day before yesterday when I walked on the room and someone said, we are having the huddle on Friday. Yes, we absolutely are having the huddle on Friday. It's fine, it's going to be there, but they're using it because they know they've already started to prepare in advance. I've got something that I really want to raise at the huddle. So the momentum's definitely there. I would argue, if anything, we are a bit of a victim of our own success because there's just so many things that people want us to cram into 15 minutes. So if we go to the next slide. The what next? Well, in relation to the time, I have often thought, do we need more than 15 minutes because there's so much? But that comes obviously with a caveat that if you are taking people out of an intensive care environment, 15 minutes is doable to get cover for. The longer you make it, it becomes more of a meeting, and then it becomes more of a challenge. And I don't think we would be able to capture some people. But there's always a temptation to think, oh God, I wish I had a bit longer. We do need to improve our communication on the outcomes and decisions, because we have had situations where things have moved really quickly. We've all agreed on something. We've come up with a nice solution, but people have felt, oh, I didn't know that had changed, because they've not got to their emails or they've not managed to get to a huddle. So where we share that is definitely, we need to think about that to make sure everyone's on board. At the moment, the huddles have been very much me to get the momentum up. And what I really want now is this, because the success of this is for me to be able to step away and say, actually, anybody can lead this huddle. And any member can come through and feel confident to do that. So that's very much where I want to get to, so that even when I'm not in the building, these are going ahead every week, and people know they're going to get the most out of them. We generate projects and it does generate work, and then that sometimes makes people a bit anxious, because they're like, oh, okay, so I have got to go away and do something because we've said, look, this isn't working, could you just order that for us, so we got a better idea. So, and then when people are under so much pressure and those short staffing, that becomes a bit of an issue. So we can sometimes take a prolonged period of time to get some information back and to keep the momentum going. But it's about sharing it. It's about making sure not the same people who come to the huddle get those projects. Otherwise, no one's going to come, because they'll be like, every time I go, I get a job. And it's about making sure that the right people are in that loop. And that seems to be working, but we've got a bit of work to do there. The longer I've talked about the building on momentum, as I say, I just want that to happen when I'm not here. At the moment, when I'm here, people are coming up to me and they really associate me with the huddle, but this is not my huddle. This is absolutely the team huddle. And that's why next step is to be able to wean it away and say, you guys can do this without me. You're doing really good. And definitely the capturing the evidence. So the quality improvements definitely going on. We are putting our patients first. This is actually not just part of what we have to do as professionals. As part, if you're in maternity services, we are actually challenged as part of our improvement plan to have QI within that. So this fits part of the picture. It's not the overall answer. I'm not saying that this is just our QI. It's only part of a big picture, but it's proven for us, certainly in neonates, to be a very, very valuable part of it. So thank you very much to the team for supporting.
Diane, that's an amazing presentation. You said it so well as well. And I've got a question, but I think there's also a question in there from Kerry. Oh no, sorry, it's a statement, which is really, really complimentary. So well done. I did have a personal question for you though. So has anything surprised you with the process?
I didn't think we would get as good engagement from the beginning. I knew I had a fantastic team. The team have always been fantastic, and they always want to do best for the patients. But even from the offset, and whether it was curiosity rather than anything else, or even just the build up to saying we're starting this, do you want to come? And people come to find out what it was. But I have to say, from the get go, we had people from across all departments. This was never a nursing, a medical, or non-clinical. It was everybody. So that surprised me from the offset of how curious, and I guess it perhaps an underestimate of how the appetite was there for QI. And I think the only thing that was stopping them doing it was the thought of it being a long project and not having the ability or the capacity to do it. And this seemed manageable. So I think that's what they bought into. They were like, oh God, 15 minutes, I can go to that. That's okay. I might get something out of it.
So well done, Diane. That's a great answer as well. Please keep the good work up. If you need any more support, please come back, because obviously we're there to help. But I think that's been quite an inspiring talk, and even I'm inspired by what you said. It was fantastic. So really well done. Now, next, I think we've got something a bit more techie. We've got the next person up, and I've lost my list names. Help me out,
Oliver.
somebody.
Oliver,
you're up to talk about your CATA project.
Yes, that's right. Thank you, Richard. So my project is the Indexor centrifuge and spun fence rollout into primary care centres. So just for a little bit of background, for those of you who don't know, Indexor is a way of transporting patient specimens from GP surgeries to the labs, and it gives us a fully electronic audit trail of the process, which is brilliant. We've been using Indexor in the lab for about 2 years now, and we've just kind of been expanding the rollout by introducing centrifuges and spun fences into the community as well. So centrifuges are bits of equipment that spin your samples around really fast and increase sample stability. And our spun fences let us put those centrifuge samples into the indexor without losing any of the important information that comes from the electronic systems when the sample is centrifuged. Using Indexor is brilliant for the labs because it allows us greater sample governance, like I say, because of this audit trail. It reduces the chance of sample rejection due to the need for electronic ordering, so we get more accurate information. It reduces the chance of losing samples in transit because the racks are properly secure in comparison to the plastic bags. Decreases turnaround times in the labs for sample processing because we can bulk process about 360 samples in 30 seconds, which is phenomenal. And it reduces single-use plastic bag specimen usage associated with the labs, which is also a win going forward. Next slide, please. Okay, so if you look at the picture on the screen there, that's how we used to process our samples pre-Indexor. So we would have piles of them on our benchtops and we would process them manually throughout the day. It was a time-consuming process and also it opened up the chance for human error. And also samples going missing either on the floor. Worst case scenario, they might roll into a bin or something, so we'd have to dive through there, PPE'd up to sort it all out. So obviously that wasn't such a good way to work. Hence Indexor. In order to continue the Indexor rollout and expand it, we had to work through the listed target requirements. So we adapted the Indexor training plan to include spun fences and using the centrifuges when we went out into the communities. We had to review a lot of data that was coming in terms of the number of samples that were coming in from each location in order to highlight sites that would be good for a pilot scheme. Once we did that, we had to reach out and liaise with senior members of the team from those surgeries in order to gauge interest and then actually conduct the pilot once they were on board. Sorry, Richard, spun fences, like I say, there are small bits of equipment that go into the Indexor racks that allow centrifuge samples to be entered into the Indexor racks without losing any of the data. Once the pilot scheme was done, we reviewed the data. And as you can see from the graph at the bottom right of the screen, the three sites that we went to eventually were Abbey Surgery in Tavistock and Callington and Gunners Lake. And they all had a phenomenal increase in sample throughput of the through Indexor in the month following the introduction of our spun fences. So we were getting more samples going through the Indexor. I think 109% increase from Gunners Lake is incredible. So we've obviously more than doubled. So it's properly worthwhile project. So once we did that and we knew that it was going to work, we then started identifying sites for full rollout. We'd obviously already had Indexor in sites previously as well, so we reached out to them as well as reaching out to brand new sites. And that obviously we've managed to succeed in doing that going forward. Next slide, please. So as our current condition, so in compared to 2023, we've seen a 9.28% increase in sample throughput across the board from every primary, like all across primary care. So we've gone from 16.42% of our yearly total to 25.7% going through Indexor now. But obviously, as you can see, we process a lot of samples in the labs. We processed over 2 million samples for the first time ever last year. So we are processing a lot of patient samples. We anticipate this number going up as we have more sites lined up for rollout. In terms of our coverage of our roughly 66 primary care centres that we have in our catchment area, 77% of them have Indexors, 44% have centrifuge, and 35 are with spun fences. Like I said, we have more sites lined up, which is brilliant. If we look at the graph on the bottom as well, we can see the whole progress of the Indexor projects from January 2023 to September this year. The purple line is the number of sites that we have with an Indexor unit in them. which is the way that we're gauging usage so far. And then the bars represent the percentage monthly total going through. So as you can see, both are on the up. It's a really positive trend. And the bottom left shows our indexor in situ in the lab, a much safer setup for sample processing than previously. So we are much happier with that. Next slide, please. So my Kata project, so looking back on how Kata has helped me with this project, I can say that it has been a successful rollout through reflective practice. Obviously, like I say, sample throughput has gone up, surgery numbers have gone up as well, which is fantastic. It's been quite a complex rollout, but actually what's really helped with this is the contact that has been initiated and maintained between the lab and primary care. It's a level of contact that hasn't actually really felt like it's been there before. So it's been a very collaborative process with primary care. And I would also just like to highlight the courier service, because they've also been fantastic in facilitating transport of the Indexor racks too. I would say that the one thing that I would have changed in this is actually how information was disseminated at the beginning. It all felt very targeted to individual sites rather than gauging interest across the board. And I feel like if we did that, we would have had much more interest in the initial stages, because everyone was a little bit wary at first. But it's all worked out for the best, so quite happy with that. We have managed to foster a continuous improvement culture in the lab and actually kind of extended that out to primary care. We've made ourselves contactable quite easily to the sites that we've been out to, so that if they ever have any issues, they can contact us, no problem. But also anyone that has any issues in the labs, they can come talk to us. We have contacts with Maxsense and Abbott, who developed the indexer. So any issues, we can always iron them out. And we always take on board suggestions. No, there's never a silly question. There's never a silly idea. We always talk it out. We work out what's the best thing to do. And in terms of working out a feedback loop from this continuous improvement culture, there's always conversations going on between management, the team within the labs, the team within primary care, like I say as well, the courier service too. It's really opened up collaborative nature in there, which has been fantastic. Thank you very much. Does anyone have any questions?
Well, firstly, Oliver, a really great description. I love how systematic your improvement's been. And you've also just reflected on how CAS has helped you, which is great. I do have one question, which is, now you're up to this level, are you going to start coaching other people?
I've got Charlotte with me and she's nodding, so I'm going to say yes.
Yeah, there you go. That's a very good. Really great. And I'm sure if people got any technical questions. I haven't seen any questions in the sorry, and you also get a certificate, which kindly Bryony or Sarah has just put up, which will wing its way to you. Really well done. And I will pass my comments on to Charlotte and to Kerry for the oversight and the work. So really well done. Great stuff.
Thank you.
So next up, I think someone's going to help me again with names. I think it's
Peter.
Peter. I would have got that one right that time. So thank you very much. So welcome, Peter. I think this is your practice coach, so you can take us through it.
Thank you, Richard. This project's a little bit smaller in scope and a little bit drier than some of the previous presentations, but I'll do my best. So I work in the clinical engineering department. I'm a senior clinical engineer in the critical care team. And as part of some of our tasks that we have to do, we look after the medical devices in the trust. And as part of this, we have to keep documentation and records of any servicing or maintenance or repairs that we do. We looked at how we were doing this, and we were using very sort of archaic old processes for doing this, where we would print a paper document out, then it'd be filled in by hand, then scanned in, and then disposed of by an admin assistant. And then we looked at this, as you can see on the left there, there's a lot of waste in this process that we can just sort of eliminate and get rid of. So we looked at how we could use the systems and tools that we have, looking at electronic documents and management methods, and how we could reduce the number of process steps from about 11 or 14 steps down to about 5, and we could completely eliminate the admin assistants from this process completely. So we looked at it and we could see that the admin assistants were spending about 2 hours of their time just on this one task, which was kind of unnecessary. And obviously the admin assistants, they're helping to run the entire department. So anytime they can claim back and get back from a process that's not needed, they can then use that to help in other areas, which helps the department be more efficient, more effective. Next slide, please. So this was originally, we measured this at the start of the year. And as you can see, on average, we were using this process about 30 times a week. Again, it was a significant burden on the admin assistants and the technicians. It takes time for the technicians to do this as well. And we worked out that we could eliminate a lot of the steps and a lot of the processes completely. And if we did that, we would save a lot of time for the admin staff, and we'd save a bit of time for the technicians, but not a massive amount, but still quite a significant saving. And then we implemented this process, and then we measured it again after a few months, and we found that not all technicians were on board with the new process, so we weren't completely moving across to our new electronic processes, which means that we have made an improvement, but it's not as much as we would have wanted or hoped for. We've also looked at now the situation we're in now. So the number of devices, the changes to our process have meant that we're now using more documentation for our devices, and the types of devices that need documentation has increased. So from September, just 1 week in September, we've now gone up to 114 jobs with documentation from 30 at the beginning of the year. So that 30 at the beginning of the year was costing the admin staff about 2 hours of time. So 114 jobs would have basically 5, 6, 7, 8, almost a full day of one admin assistant just sitting down, scanning and disposing of documents, which is very wasteful and unnecessary. But even the technicians who weren't going to save that much time, one technician could have saved about 27 minutes of their time in September in 1 week just on this one particular process. And that's basically another job, another task that they could have completed, which again helps with our workload. Next slide, please. So as I was saying, so we didn't fully implement this as effectively as we could have. We made about a 60% improvement rather than the much higher improvement that we could have made. And we started to discuss why this was. And it seemed to come down to a fact of in the department, we're quite siloed. So the admin assistants, this would have really benefited them, whereas the technicians is a small improvement, but not massive. And that there wasn't the communication or the involvement when we were designing and running the project across all the groups, which meant that they couldn't see the improvements that may not have been present for themselves, but would have been present in other areas in the department. And obviously that would eventually have an impact on them, but not directly. So we've taken that on board, and we've realized that we do have bigger issues in the department. So again, this siloed sort of atmosphere that we've got, we need to start looking at that, and any further improvements or changes in the future, especially bigger changes, bigger improvements, we need to basically highlight that and really focus in on that and break it down those barriers if we want to actually make some bigger changes and bigger improvements. Additionally to this, so as an add-on to this project, we also looked at using our system. So we've got 2 different software systems, one for managing our documentation through a QMS system, and our asset management system. And we realized that we could sort of link the 2 together, and we can actually access our documentation through the asset management system. So these 2 independent systems now they're not talking to each other, but you can access one through the other, which again saves a massive amount of time and reduces basically the documentation. When you open up a job to do on whatever it is, the documentation is already there, ready to go. So you just need to fill it in. There's no looking for it. You don't have to sign into anything. You don't have to open up additional software. And it's an improvement that's come about because of this previous improvement. So one small project has led to another project, and hopefully this will lead to more projects. And again, these small improvements all add up over time. Yeah, so it's been quite a beneficial task. Thank you.
Really well done, Peter. I think we just go to the next slide. You do get a certificate, so really well done. And I'll just want to compliment you and Kerry for the training as well. Some of your slides are amazing, but I really like your graphics. So it was also one of the shortest slide packs I've ever seen for a practice coach, and that's not a criticism, but it's absolutely succinct. So really well done. I really like the fact you got an added benefit and then another bonus. I guess my key question, and if anyone else got a question, please put it in the chat, is will you continue using some of your practice coach skills?
Yeah, definitely. Some of the different lean methods have come in handy. Again, we've started to implement more projects, and using the 8-step is a really good way of visually representing everything in a very, as I say, a succinct way. And I found that really, really helpful. And just the change management aspect of it and how you manage people, that's the bit that I think we need to focus on. That's the actual hard bit, as far as I can see.
Yeah. Well, really well done. So thank you very much, Peter. There isn't any more questions there, so there's lots of compliments, which is really fab. Can I just compliment everyone today? And I think Diane touched on it in her presentation about her huddle being an MDT, but today we've had cardiology wards, clinical admin from ENT, the NICU team presenting, labs and medical devices. I mean, that's a great cut through the hospital. So really well done, all of you. It's really great to hear from it. I will be circulating this presentation recording to the execs later because they couldn't join today because they're in another meeting. So I think it's absolutely fabulous. Yes, Sarah's just on. Oh, no, I'm going to be reporting out. I just saw your exclamation. If you want to talk about that, Sarah, we can. I'm sure you've got some really great news for us on the work that you're already doing.
Absolutely. Absolutely, I'm on it, Richard.
Thank you very much. I think there's another Oliver from CSS. I think there are going to be 3 really great presentations from the RAI who've been working really hard in the last few weeks to make a whole series of improvements. And Nicola's going to come up from theatres and talk about our process checks, and there will be a few more. So it will be worth getting in your diary if you want to come along. We'd never exceed the hour. Oh, it's the same Oliver. He's been really busy. Right, okay. Right, well done, Oliver. So thank you all very much. And that's it for today. And thank you all the presenters. Thank you very much. Bye-bye.
Thanks
Bye,
all.
thank you.
Bye.
Thank you. Bye.